Morning, good afternoon, and good evening. Welcome all of you to the live program number 169 at Orthopedic Principles. Today, our guest of honor is distinguished faculty Professor Heinrich Baum from Bad Berka, Germany. Professor Baum trained and worked in the spine centers with Professor Klaus Zielke at the German Scoliosis Center and Professor Jürgen Harms at the Karlsbad Langensteinbach. After the fall of the Berlin Wall, he founded and for 25 years directed the major spine center at the Zendel Clinic at Berka, Germany. His clinical and research interests encompass minor access surgery techniques to the thoracic and lumbar spine and the development of adapted instruments and implants. Another focus is cervical spine, including the transoral surgery, with emphasis on reconstruction after multi-level corpectomy or rheumatoid destructions. A new field of his interest in recent years are long-term studies of fusion, namely after vertebral body replacement and deformity corrections by means of machine learning. Today, it's my great honor to introduce you to Professor Heinrich Baum from Bad Berka, Germany. Over to you, Professor Baum.
Good afternoon and good evening. Dr. Gopalan, thank you very much for giving me the opportunity to share my thoughts on spinal reconstruction and mainly on prone thoracoscopy with you. And I feel very honored to have the chance to do so. And I hope that sharing these thoughts will help all of us in maybe finding better solutions for the challenges we are having. Now, my disclosures, I am getting royalties for patents on spinal implants and instruments, mainly for less invasive surgery. Now, please excuse me for getting back to some basics. While most spinal deformities are kyphosis, and that is due to the lack of anterior stability problems or problems with the tension band function posteriorly. And so the primary problem usually is anterior. And so it would make sense to do the repairs of the anterior column and possibly fixing the posterior column as well from anterior in this first situation. And regarding the second situation, again, the lack of the tension band has brought some problems to the anterior column, and to fix that, usually by fusion and combine it with the posterior fixation, might be a good thing. And above that, even in thoracic lordosis, which are rare, but even so, correcting them from posterior alone can be quite a challenge. And now the treatment of anterior problems by posterior approaches in the last decade or so has reached worldwide acceptance, and with techniques like PSO and VCR, one can yield excellent results. So you might well ask, is there really a value for prone thoracoscopy? Having the second method, adding second problems to the posterior go, which is necessary anyway? Well, I try to convince you that there is a role, and particularly in Europe, and maybe not only in Europe, we are having an aging society with tremendous rates of multimorbidity and the resulting problems due to implant loosening, implant failure, compliance, and post-operative infection. And particularly post-operative infection can pose severe challenges if you have a destabilized spine that is only fixed temporarily on some screws and some rods. And so it might be advantageous to have short constructs and short instrumentations, to have a reduced trauma of approach, to avoid or have a reduced muscle detachment posteriorly, to avoid additional, so temporary destabilization of the posterior column just for solving a stability problem of the anterior column. it might be necessary and advantageous to preserve osteoligamentous structures as hinges between the cranial and the caudal spine when, for example, doing a major correction after a osteotomy from posterior, and to avoid dividing bilaterally the vessels which feed the dura and the cord just for gaining access to the anterior spine. So it might be advantageous to operate as well from the front. But conventional transthoracic approaches are not really a solution. They require a combination with a posterior approach. They are time-consuming. Open thoracotomy or lumbotomy require a substantial trauma for the approach. And to reposition intraoperatively a destabilized or partially destabilized spine might be a challenge as well, which one likes to avoid. So sometimes when embarking on a transthoracic anterior procedure, 2 stages are necessary. And above that, the problem is remaining that for example, in post-traumatic deformities, anterior and posterior goes are done. So let's say one starts posterior, goes anterior, goes posterior again, but still there is remaining an anterior defect which is not filled after the second posterior goes. So that is not really a good solution. And this is why worldwide people have mainly left the anterior approaches in favor of one bigger posterior approach. So if we think on requirements that an improvement to this posterior gold standard would mean regarding safety, regarding reduction of aggressivity, then another point is that if we add a second approach, the addition of the possible complications of the 2 approaches must be less than of one big posterior approach. The total surgical time should be at least comparable, or better, should be shorter. The surgical infrastructure and instruments for all that should be available or need to be available and affordable, and it has to have the same indications as for open surgery. Now, as depicted in the starting video, the prone thoracoscopy allows circumferential and simultaneous or repeatable access to the anterior and posterior spine. In this example, posteriorly, the percutaneous screws are placed in an ankylosing spondylitis case here, and then intracostal approach is done for the mini thoracotomy and in the same level for the endoscope. Regarding thoracoscopic technique, that was first introduced by Jacobeus of Sweden in the late 19th century, and then for quite a while only used by pulmonologists or thoracic surgeons, usually in the treatment of tuberculosis. It was Mac and Regan who in 1993 then published the first application to the spine. I was for a long while looking for a method to have simultaneous approach to the thoracic and lumbar spine, and so after some animal experiments I started doing in a lateral position thoracoscopic surgery in 1993 and changed to exclusively prone position in 1996, and ever since in my department we are doing everything in prone position because of the advantages I'd like to show you in the next slides. We first published that in or presented it in the IMAST 4 in 1997. Now, regarding the preoperative considerations of surgery in prone position, there our friends from anesthesia have to be closely involved regarding the question whether we need double lumen intubation or whether single lumen intubation is enough. Usually, single lumen intubation is totally all right, and we do not need double lumen intubation. Only maybe in mid or upper thoracic it is useful, but it's not a must, particularly if you have jet ventilation available for, let's say, the act of implanting or putting the implants in, or when we place the retractors there to have the lung out of the way is quite useful, but normally we do not need a double lumen intubation. Regarding spinal cord monitoring and narcotics, it's the same as in any other surgery. Blood loss in thoracoscopically assisted decompression is certainly the same as in open decompression. It does bleed when the dura is decompressed, and so cell saver is a good thing. And regarding a side-off approach, I will come to that later. Regarding thoracoscopy directly, we need a video tower, a second monitor. It would be quite nice that the assistant and the anesthetist can watch as well. Regarding the side-off approach, at the thoracolumbar junction, if the pathology is not showing or demanding anything different, the left side is better because of the height of the cupula of the diaphragm. But in the mid-thoracic area, where the aorta obstructs the left side and would require to divide more segmental vessels, there in the mid-thoracic area, the right side is a better side of approach. And above the aortic arc, it doesn't matter which side. I usually prefer to have the right side as well. Should there be a scoliosis in the thoracolumbar junction, then if we do not want scoliosis correction, but any other things, if we come from the side of the concavity, because there we can reach more disc spaces easily. If we want to use it for scoliosis release, then certainly we come from the convexity. I come to that later. It is possible in prone position to access lesions from the disc T1, T2 down to the disc L1, L2. In some scoliosis, even to L2, 3. I'll come to that later as well. Pleural adhesions are usually not a problem. Pleural adhesions can be divided under vision of the thoracoscope, and that works comparatively well. Now, the requirements in detail, we need one portal for the endoscope, a 10 millimeter portal usually, and a 30-degree angulated thoracoscope. Short shaft is advantageous to a long shaft, but it works with both of them. 3D video is nice to have, but it works without, only in cases, let's say, of a calcified disc or a extended decompression of the dura. There 3D certainly is nice and gives a much better vision. Then the second of our two portals is the intercostal mini-thoracotomy. If we have to do just an interbody decompression and a fusion, it is 2.5 centimeters are enough. If we need to get a vertebral replacement into the chest, then we usually open up to 4 centimeters. But always we can avoid resecting ribs. It is possible to introduce that just in between the two ribs, and all manipulation instruments are put through this working channel. It is not necessary to have more openings for standard situations. Here on the right, you see with a posteriorly open situation, the setting with the thoracoscope, and in the same intercostal space, the working channel, at that time there with a navigation system for anterior. And from the scheme here, the schematic, you see that we use the intercostal space usually at 10, 11. Now, in the beginning, I always looked at the coronal plane imaging, and this can be quite scary if you see where the cupola of the diaphragm is, but this is misleading because we are going posterior to the cupola, and what is important is the insertion of the diaphragm at the chest wall. That is important on whether you reach T12, L1, or L2 or not, but usually just by detachment, small detachment of the diaphragm with a Cobb elevator, one can easily come to L1, 2. One just has to be careful of the feeder, of the segmental vein at L2, which sometimes can be quite big. Now the position of the team, surgeon can sit on the side of the approach. The assistant is opposite to him. Video screen for each of those is advantageous. The nurse is next to the surgeon and the anesthetist where he needs to be. Regarding instruments, I don't like these fancy throwaway single-use instruments. They're not necessary. It's mainly standard instruments just adapted to length and some other small issues, but it is the instruments we know, like a Cobb elevator, like rongeurs, like scissors, and so on. 3D thoracoscope is nice and interesting, but as I said, not a must. Now, regarding the steps in sequence in the two-portal technique, the approach to the chest is that we do our skin incision in the posterior axillary line. The anesthetist then deflates the lungs, and then by just spreading the intercostal muscles parallel to the ribs with a scissor and open up the pleura in the same go, and giving a place for putting in the retractor is the first step. And then in the same intercostal space, under control of the palpating finger, the thoracoscope is inserted, or the portal for the thoracoscope is inserted. Then adhesions, if necessary, are divided. The retractor blades secure the aorta, the diaphragm, and the lung. And then the next step is to identify the rib heads and the anterior border of the vertebral bodies for the next retractor to be put in. This is how it looks, the chest wall from inside. And here, opposite to that, the diaphragm. Adhesions can be dissected often bluntly, as I showed in the starting initial video. And then the next step at the approach of the spine is the splitting of the prevertebral pleura at the posterior aspect of the body. And for the thoracolumbar junction, the detachment of the psoas and diaphragm en bloc with a sharp Cobb elevator is giving free L1-2 disc or L2 corpus. Then by blunt dissection, the pleura is dissected and put away. Often one can preserve the feeders, the vessels, and then the diaphragm, if it's very much coming cranially, one can just buy some K-wires which are fixed in the vertebral bodies to put it away. Regarding segmental vessels, if they need to be divided, it is perfectly okay just to ligate them as we do it in the normal situation. The only help is a knot pusher, like we know from arthroscopy, that then allows us to have a safe division of the vessels, and then to remove the discs or remove a vertebral body, to do a duro deconstruction. Particularly for reconstruction, cages are quite advantageous over cortical-cancellous bone graft because of the handling, which is much easier with cages. Indications are the same as for open surgery, and I would like to go with you through some of the main indications for I see for anterior surgery. So, for example, calcified midline discs is difficult from posterior to reach, and so here it can be done along the same lines. Here you see that it's completely resected and the dura is extended again. Regarding fractures requiring interbody fusion or corpectomy, I took an example of a young owner of a fitness studio who had an accident with his mountain bike and then complete paraplegia right from start with his luxated spine. Here the MRI and the CT scan showing, as usual, that posterior elements are not much affected. Posterior elements usually are not broken, but if you have fragments and you open up for conventional open approaches, then you will have the problem that you have to remove them. In this example, we did it in a transtubular way to here resect the cranial portion of the joint, which you can see here, the joint cartilage, in order to allow for a safe reduction. But our subject is anterior, and so here you see of this patient the avulsed disc 11-12, and from the initial MRI we knew that there is a huge traumatic disc prolapse, which then subsequently here is taken out. That is the first portion of that, and there is another big part being removed in the same way, and you see we don't need much affecting the environment of this problem for taking it out. Sorry, then just as in any interbody reconstruction, cage-assisted fusion, the cage filled with graft. This is the intraoperative images of the percutaneous fixation. We took one level more temporarily on the caudal side because of the destructed T12. The approach for the posterior transtubular decompression of the or resection of the joint is done here as well. We only have these 6 incisions, and anteriorly here the retractor for the mini thoracotomy and the portal. This is a postoperative image, and after release of the lower segment after 3 months. If you should be more interested in more details about that, my former co-worker Ahmed Shawki has published that in the European Spine Journal and done a very good thesis in getting all the details regarding side effects and complications and so on. Now let's go on to spinal infections. In spinal infections, they are a big problem in our society because of the elderly polymorbid patients with diabetes and renal insufficiency and so on. And there, a small surgery, a less invasive surgery is quite advantageous. Here you see the adherence of the lung, and that it's comparatively easy to just to get it out of the way. Regarding infections, we follow the concept of Stolze and Harms with a radical debridement, a filling of the defect, local antibiotics, and achieving mechanical stability as much as possible to allow a vascular reconnection of the injured area for the systemic defense being able to approach that, and antibiotics, systemic antibiotics again being able to approach it, and that bony healing can take place rapidly. This is after 2-level corpectomy of a infected spine, with duration 3 years afterwards, with a good and complete healing. Should you be interested more in these aspects, another very good co-worker, Abdel Rahman, has dealt in detail with preoperative imaging with comorbidities, and you see there are quite substantial comorbidities in these patients group we are faced with in Europe. Operative time is here anteriorly, posteriorly, with spinal cord decompression. Usually it is longer than when it's not necessary, but it is under 2 hours only. In cases of corpectomy, it is a little longer. The intraoperative blood loss certainly is substantial, but below 1 liter. 4 patients of this series died within 1 year, but usually they are comparatively old and polymorbid, as I said in the beginning. So the advantage of these thoracoscopic way in prone position in pyogenic spondylitis is that we, even if we compare it with open thoracotomy, we need less pleural adhesions to divide because our working channel is smaller. The orientation is easier because we have the same position than for the posterior go, and much easier than the lateral decubitus, where it's always difficult to decide whether the patient has rotated or not. The application of corrective forces is easier, for example, to correct kyphosis. The option of simultaneous posterior release of epidural abscesses and so on is there, as well as the ability to have posterior percutaneous stabilization. If we apply it to deformity, on the example of scoliosis, one can do it just from posterior as one usually does, but if one sees that the correction of the hypokyphosis or of the derotation is not enough, then one just can add this anterior go, and by direct manual apical derotation after removing the apical discs can just easy up the implant fixation and correction from posterior. Likewise, in ankylosing spondylitis, when we have anterior osteotomies or problems for debridement of Anderson's lesions, it is easier to do it in a combined way with a small posterior approach and doing from anterior the release in order to ensure that the correction is exactly at the level of the spinal cord, and so that there are not big length discrepancies or the length shortenings there. This is another case of ankylosing spondylitis, an Anderson's lesion and an incomplete paraplegia due to that, the pseudarthrosis, so to speak. Here, a corpectomy cage had to be implanted to correct it. You see that is quite different, the posterior wounds, in comparison to, let's say, a VCR or PSO, and this is a lady a couple of years after. It's in tumors and metastases. Again, the posterior elements mostly are unaffected. It's a failure of the anterior column that causes the problem, and due to the better oncological options in recent years, spinal surgery more and more is a co-worker just to bargain time for the for the oncologists to treat lymphoma or plasmacytoma or so on. And that's ideal for thoracoscopic corpectomy and posterior percutaneous fusion. One aspect here is that if we use cannulated screws from posterior percutaneous ones, you just can put in a K-wire through the cannulated screw. That helps a lot for orientation, and usually we need X-ray only for controlling at the end of surgery whether the implant position is correct or not. Anything else is allowing being done by the information we have from the posterior implants. Here you can see the dura is free, and if you look carefully, it is pulsating again, and we can clearly see the relation to our implant. Usually expandable implants are very helpful in thoracoscopic surgery because it's difficult otherwise to get in the forces. So in summary, prone thoracoscopic surgery saves time because no intraoperative repositioning is necessary. It allows a simultaneous approach and therefore increases the options in complex deformities, for example, in post-traumatic or other kyphoses. Vision is better than in open surgery because blood follows gravity and such is away from the operative field. Assistant nurse and anesthetist can follow directly over their video screen what happens and what the surgeon does. We can do a titrated release. That means we have a posterior release, and after the anterior release, you find, oh, it's not enough, we need more. Then we just switch over to the side and can widen the osteotomy. It's not a problem. So we need not in advance to do more than absolutely necessary to get the optimum result. Anterior grafting as a last step after posterior compression and fixation is easily possible. The integrity of the chest cage is untouched since we do not need to cut ribs, so there is less postoperative pain, and we virtually do not have post-thoracotomy syndrome. And an Indian spine surgeon, Nirmal Patil, who helped us in evaluating long-term results of these thoracoscopically operated patients, found out that post-thoracotomy syndrome in these cases is not a problem. What a problem is a demanding surgery, which it is, with a long learning curve. So thank you for your interest, and I'm eager to hear your comments or questions.
Thank you very much, Professor Bohm. Fantastic lecture, and really very happy to see the cutting edge work that you're doing in Germany. Professor, a few questions that have come up. One is, which is the best indication in your hands? Do you think scoliosis is one of the good indications because you can look at releases at multiple levels?
Well, I thought that initially, but in recent times, when the scoliosis correction methods got better and better, we only do it, we started as a normal scoliosis and then only do it when we see, oh, we don't get rid of the hypokyphosis. We want 10 degrees or whatever more, then we add it and can do closing wedge in 1 or 2 levels, and then it's a good thing for scoliosis. But to come back to your question, now it is the pyogenic spondylitis, which we have many cases, and the tumors, metastases, where we do from posterior just the percutaneous fixation and then a corpectomy. That's straightforward and fast, and these patients then are, we don't have to fear posterior infections, delaying the oncological treatment and all that. So that's what I would regard as is the best indication.
Thank you, Professor. The other question is regarding lung function. Now, sometimes you have patients with ankylosing spondylitis, they may have a compromised lung function. Also, in patients with scoliosis, severe scoliosis, they may have a lung function, and you may resort to single lung ventilation, isn't it, for these thoracoscopic procedures? So, are they a contraindication, or how difficult is it?
Thank you. Well, that's a very important question. The lung function is certainly a problem in severe cases. It is, but it's not during surgery. During surgery, usually the oxygenation is very well possible with just having the lung collapsed to some extent on the side, and it still gets some oxygen exchange, particularly when the anesthetist then goes to jet ventilation. The problem in ankylosing spondylitis is postoperatively. We all know that they do not have breathing by changing of the ribs. They only have a breathing of the diaphragm. And this, in fact, was my first indication that in those cases where we formerly did thoracophrenolobotomies for ankylosing spondylitis and found, oh, that's quite difficult afterwards for them to get on with the breathing, I started to do thoracoscopy and lumbotomy in order to have the insertion of the diaphragm untouched. But back, yeah, it's usually not a problem, but it is important post-operatively to have a close eye on pleural effusion, on the chest tube, that it works, that one gets everything out, and then even in patients with COPD, which we have a lot, it is enough for the anesthetist to get the oxygen in. Sometimes it might be, and we had it that, or in very severe scoliosis, that the anesthetist said, well, oh, now wait for 5 minutes. I have to inflate the lung completely and get the oxygen up again. So that works well. And one has to say one limitation in very severe scoliosis and thoracoscopy is that you simply do not have space if the spine is just touching the chest wall in let's say 120 degrees or so. There it is not possible. Or what we usually do is that we start to get as much correction as possible from posterior, and then when we have corrected it down to let's say 60 degrees or so, we see in the image intensifier, okay, now we have space for going anterior and then doing the anterior release, or usually a partial corpectomy in those cases, in order to have enough mobility for that. But very severe scoliosis and prone position thoracoscopy does not make sense.
Thank you very much, Professor. The other thing is, in all of your cases, you're mostly instrumented from the posterior side, isn't it? So can we do a thoracoscopy approach and do an anterior fixation? For example, you put screws into the vertebral body and fix the anterior spine.
Yes, one can do it, and I did it in the beginning, and I'm sure you're aware of the anterior scoliosis correction of Peter Newton. He did for some time. I'm not fond of that at all. I think the transpedicular fixation is so much superior to any fixation from the front, and long term, if you have any problems, it's easy to change it from posterior, but rethoracotomy for such things would be a big problem for this patient. I don't do any anterior fixation anymore. In particular, since after, let's say, 2006 or so, we posteriorly, most cases perform just with percutaneous fixation. And so there is really no point for me to try a lengthy, time-consuming and not ideal biomechanically not ideal anterior fixation. I don't believe in that. I don't do it.
Thank you, Professor Baum. Professor Nirmal is also there in our Zoom room. Nirmal, Professor Baum is here, and if you have some questions to ask Professor at this moment, you're welcome. Nirmal.
Hello, sir. Excellent talk. I had a question regarding the learning curve. As you mentioned, the learning curve is quite steep. So for young surgeons like me who want to adopt this thoracoscopy in their practice, which cases would you recommend starting off, and which levels would you recommend choosing? And then how should we gradually progress down our career?
Well, the best level is 11, 12. And if the pathology does allow you to come from the left side, there it's very easy. The anesthetist who has a learning curve himself is at ease, because when he just deflates the lung a little, it is totally enough, and then he can do his machine just as before. And for the surgeon to take out the disc is, as he knows from open surgery, and if he then let's say after 10 or 15 cases feels comfortable, then I would not do a dural decompression before that, but after this experience, and namely getting acquainted to the landmarks on where is the spinal canal. That is the most important thing. And this in a prone position is comparatively easy, because if you take the rib heads then and look in the preoperative CT or MRI how far they are posterior, you know, okay, now it's 5 millimeters to the canal or 3 millimeters to the canal, and then you gradually go on there. So these decompressions, let's say in fractures or in pyogenic spondylitis, are the easiest. Pyogenic spondylitis can only be a problem if it has led to adhesions, and so I would start out with non-infected cases, then like fractures or instabilities, and then go on to corpectomies for tumors, which I find comparatively a good example for learning to do the dural decompression, and then go on to the more difficult cases.
Okay, thank you very much, sir.
Welcome.
Professor, I think there are no more questions. Thank you for this fantastic lecture. You have published so extensively on the subject, and we are very honored to have you on board. I mean, there's no other person who can speak on this particular subject. Thank you very much for joining in, and really look forward for another lecture later on whenever you have time.
Thank you very much for giving me the opportunity, and I feel quite honored to be part of this excellent endeavor you're following, and I'm sure this is a very good platform for all of us to get updated in a very convenient way and a very effective way. So thank you very much again, and yeah, hope to see you soon, sometime, somewhere, and stay healthy. I hope that current problems do not affect you too near.
Thank you very much, Professor.